So a little bit about Dr. Anderson. He's known among the Ewing osteosarcoma and DSRCT communities around the world as one of the brightest, most compassionate, creative, and out-of-the-box oncologists. He never gives up. He always has a plan. His work in immunotherapy and radiation combination therapy is charting new territories. It is an incredible honor and privilege to introduce Dr. Peter Anderson to our community. Please help me give him a warm Fort Worth welcome.
So today, I'll talk to you about some targeted therapies. First of all, there's quite a few slides, but the purpose is to give you hope that cancer therapy is improving in ways we never imagined. We'll talk about treatment of solid tumors, and this is my usual disclaimer. When we deal with rare diseases, the drugs we know are effective are commonly not FDA approved, but we like to publish papers to allow us to use them. I've also been privileged to be part of a team that looked at ways to decrease the toxicity of cancer therapy. So when we treat solid tumors, there's principles of therapy that you may or may not know, but what we call local control, the surgery or radiation, is always important. And then we try to reduce the side effects of our therapy, and we call that the therapeutic index. Really, how specific is the therapy? And unfortunately, many of the old therapies are not very specific. So it's very important to try to mobilize all the resources you possibly can to have a better outcome. And the immune system is one of those, and you'll learn about that today. I got interested in how well the immune system works against Ewing sarcoma, Carley's disease, when I had fellows, so doctors learning to be oncologists, do a study. We already knew from some other diseases that how fast patients recover their lymphocytes, immune cells, after transplant translates into survival. So he said, let's look at this for Ewing's. And sure enough, it was quite important. If you recovered your white cells, called lymphocytes, quickly, you did better. So using this principle has guided me to try to get therapies like the Vigil vaccine into patients. It's also true for osteosarcoma. It's not an uncommon consult I'll have either face-to-face or with a virtual visit where it looks like the chemotherapy is not doing what it should. And I remind the patients if their lymphocytes recover quickly after the very first cycle of chemotherapy, we can tell they'll do better than expected. So one of my good parts of my job is to provide hope, knowing that the immune system can finish what the doctor started. In terms of local control strategies, we're also much better at that. People are familiar with surgery, but radiation has improved a lot. Instead of 5 or 6 weeks of radiation, it's not uncommon to get all your radiation in 1 week now. At Cleveland Clinic, we'll have 5 days of radiation, then they go to surgery. So, and it's much easier for the family, the patient, and the doctors to have the therapy much more quickly. And then finally, there's ways to freeze tumors. Interventional radiologists are special doctors that are good at biopsying tumors, but now they also treat them. So under CT guidance, they can put a probe right into the tumor, watch an ice ball form, and say, oh, it's now 4 centimeters. We've done enough. So then they let it thaw. Now I've seen them actually take a coffee break while they're letting it thaw. And then 10 minutes later, they'll freeze it again. So they're overachievers to make sure the tumor is 100% dead. So when I explain this to a teenager or young adult, I'll quote Zombieland. The double tap is what the interventional radiologist is doing. And then they understand. And this shows one of the radiation techniques. They'll do a treatment plan drawing a circle around the tumor, but you can see it's a very specific area. In this particular case, the young man already had an amputation on one side and had it in his sacrum on the other side. So surgery wasn't an option, but with stereotactic radiation, he was back into the game with his favorite hobby, which is climbing, and it's way better than any of us in the room could do. This is another example of cryoablation. You can see the probe going into the tumor. What I like to think of it is it's an outpatient procedure that takes one morning, and then the patient goes home. So it's much easier on the patient than surgery or radiation even. In Hakan Ilasan at Cleveland Clinic, I'll have a patient come and I'll call him up. He'll come right over to our clinic and talk to the patient. They decide which day is good for them. So we're getting better at local control, but trying to improve the therapeutic index, how more specific our therapies is quite important. And I give patients the expectation that they'll do well, and they'll often rise to it, particularly if they're children, adolescents, or young adults. And the children, I tell them, if you can play, you're okay. If you stop playing, then your parents and I have to worry. And nutrition's very important. Cancer patients will get all sorts of advice, much of it very well intended, and get very confused. So with my nutritionist, we'll go over the principles of good therapy, and I'll give you some ideas today too. So all of us have family members with cancer, but how to mobilize their thoughts and ideas, what will actually help, we'll talk about in a second. And then, just because you're trying to get damage of the tumor, what you want is the normal tissues to heal much faster. I had also a good experience with a patient with a Ewing's family tumor that taught me. So I'm learning from patients and families literally every week something new. And she had a hard time convincing her oncologist that she had to come to Cleveland Clinic for special surgery, then get additional, I'd say, lightweight chemotherapy with radiation back at home. And what she did was she stopped using the word cure, because it makes an oncologist, especially a surgeon, to think they have to do everything themselves. And she said, she had 4 children. She said, I just want to be the statistical outlier, which resonates with doctors. That means you're on the survival curve for a long time and just wants a chance. So often in the virtual visits, I'll teach families how to talk to their doctors, nurses, and consultants. These are the papers that influenced me in the last 2 years about the importance of nutrition. It's not just not losing weight. If you're so inactive that you have to digest muscle to provide nutrients like glutamine to the intestines and white cells, that's their fuel, just like glucose is for your brain, you do worse. And these studies were in breast cancer patients. If they were losing muscle mass, and you can see this from the CT scans that they do, they had more hospitalizations and worse survival. So it's not just a good idea to have better nutrition. Sometimes your life depends on it. So what can you do? So this weekend I said, this is just all talk unless I show a picture. So I took pictures of the foods I commonly recommend. And when you go through the grocery store and look at yogurt, choose the high protein variety. I like Feuillet, but it comes in a number of varieties. When you choose milk, there's a special kind of milk out there called Fairlife milk that's ultra-filtered. It has twice the protein, half the sugar, it's lactose-free. So I'll have my patients say, I don't feel like eating. Well, I say, well, at least drink something nutritious. And for kids, you can mix the white and chocolate milk. The other is kefir. And people say, well, what is kefir? And I say, well, it's kind of like Go-Gurt, but it has different good bacteria. This is particularly important for the Vigil trial because they also get 2 chemotherapy drugs. One, irinotecan, is hard on the intestines. But if they have fiber from berries, bananas to decrease diarrhea, good bacteria, and then a supplement that I invented, full disclosure, there's a tiny little company called Helios that does this. They commonly will have normal quality of life. They'll be able to take the irinotecan orally at home, and it's boring. So I say, my job is to have your life be boring in terms of what you do. If you want to try the experiment and see what kind of GI side effects you have, go for it. But this is the way I recommend not just the vaccine, but good nutrition. So we've talked about these things. And the vaccines are really kind of amazing. I'll show one quick slide also. There's 2 kinds of immune cells. T cells, which the vaccine works with. There's also natural killer cells. And the Rutledge Foundation helped me start a investigator-initiated clinical trial with a new drug, ONC201, which increases natural killer cells. And it's probably the least toxic chemotherapy drug I've ever used. People take 5 pills once a week. They go to work, go to school. And it's been effective for DSRCT. What we want to do is try to get patients at a much earlier stage. I have a patient coming on Monday who's been on the drug for a year now. And she's got 3 children. She leads a normal life. And we're saying, how long can you get it? So we had to rewrite the protocol so that she could get it longer. Also, the company that makes this is a beautiful little company called Oncoceutics. So they're not like some of the big pharmas to deal with. There's so many layers, and they do a market analysis and say, Ewing sarcoma, that's not very common, we're not interested. Instead, they've looked at the side chains of the molecule, and they have even better molecule for what we call Ewing's family tumors, or primitive neuroectodermal tumors, ONC206. So we've written a small business grant, and hopefully in 2019 we'll do ONC206 too. I learned this is why doctors need to travel instead of just stay in their office and look at the internet for new papers. I learned about this drug, ONC201, from Andrea Hayes Jordan when I was in Toronto. We'd worked together for years with DSRCT patients, but her lab showed that it actually worked in the lab. So it said to me, take the time, write the trial, try to get the money. I got the money from a number of different organizations, including the Rutledge Foundation, and make the effort. And it's made a difference. When we've looked at tumors, there's 2 varieties that really highly express the receptor. One of them's paragangliomas, and the other one's the primitive neuroectodermal tumors like Ewing's at the top bar of the sarcomas. So the science sometimes develops in tandem with our ability to do things. And we now have a trial that's not only open, but within a year we put on 4/5 of the patients. So it shows the world's become a small place, patients talk to each other, and they'll come to places like Cleveland to get on clinical trials. The next is the Vigil vaccine. These slides are from other publications, but it shows it's very high tech. 2 genes are put into the tumor. The tumor's irradiated, and vials of vaccine are made. What's important about this is it's designed so that on a clinical trial, you can essentially get a booster every 3 weeks. Now, how many of you have had a flu shot? So once in a while, you'll get a sore arm, but the side effects are pretty minimal. This reminds me more of when I worked with animals and had a laboratory. I had to get a rabies vaccine. The first time, no side effects. The second, none. The third, then I had a slight sore arm. So what we're trying to do is get the immunity more and more with each dose. Yeah, we know on its own, it's probably not going to be enough to get into the clinic because we already have chemotherapy drugs that do something. So we did a phase 2 trial with temozolomide, irinotecan, well-tolerated chemo drugs, and worked out the logistics to do a phase 3 trial. In that trial, it was surprisingly active. This is an example. If you look at the yellow spot on the PET CT, you can see that tumor was gone on this kind of therapy. And so when you are in the exam room showing scans to the patient, it's not scientific, but I say, yippee. And he actually came from Iowa to Cleveland to get the vaccine every 3 weeks. He also had a complete response in the sacrum, so it really does work. So after he had used up all 12 vials, we were saying, what do we do now? You're doing so well. So we biopsied the tumor, and it's 100% dead. There's no active cancer in a lung tumor that we biopsied, and same with the sacrum. So this was like convincing evidence to doctors. They say, well, your patient's doing fine, but maybe the tumor's just going to grow. This was really promising. So now we're a phase 3 pivotal study, and this is from clinicaltrials.gov showing what it looks like. Finally, I like to do new things every year. In the past year and a half, probably my life changer has been virtual visits. And with Facebook connecting more patients than ever, they commonly will get my name, but instead of fielding lots of phone calls and emails, and a little guy like me getting confused, what I do is say, organize your information in a half page, get a Cleveland Clinic medical record number, upload your scans yourself, get a CD. And the motivated patients and families do this within a couple days. And then on a Tuesday or Thursday, we have a conversation. It's like looking at your cell phone on FaceTime, but it's HIPAA secure. So in a half an hour to an hour, I can edit a summary and then email that back to them with images of their scans so they are ready for what's next. So if a patient's diagnosed with metastatic Ewing's up front and we know their chances of relapsing are high, hopefully in the future they'll be ready for the Vigil vaccine if they do have a relapse. And then last but not least, I'll give you 3 points. Please share this. You can write this down. If you don't have something to write on, you're welcome to email me too. But the first is patients and their doctors get tired. I'll admit I'm better at the beginning of the day than the end of the day. So how to avoid battle fatigue? We had a family create a website. For anybody with a chronic illness can use this. It doesn't have to be cancer or childhood cancer, but they understood. So it combines features of Caring Bridge to let friends and family know how they're doing. It also has a feature like lots of helping hands. So it's a calendar. You can assign tasks like mowing the lawn, taking the other kids to school, waiting in the clinic, babysitting other kids, putting gas in the car, making meals. All these things we take for granted. It helps families get organized. And then last but not least, it has a crowdfunding feature. So if they need to go for a consult or they have high copays because their insurance isn't good, they can get these extraordinary therapies by organizing their friends and family. The next is access is easy to arrange. Of course, I like to see people face to face. And if it's summertime in Fort Worth, just for your information, Ohio is a garden spot. You can come visit Cleveland and it's temperate. It's low to high 70s. We're near Lake Erie. But the alternative is from your own home, you can do the virtual visit. That's easy to arrange. Usually I'll send 3 to 4 attachments how to do it. And then last but not least, help the Rutledge Foundation. They are a catalyst for good. They are doing important and really innovative things. And your being here today is part of that. And I'm so blessed to be able to speak here to you and to share the things that they've done that have made a difference for so many. Thank you.